Welcome, everyone, to the 185th 988 Crisis Jam. Good afternoon, good morning. We're going to be talking about medication-assisted treatment, or MAT services. I should also say that you'll hear some other terms for MAT. So you might also hear MOUD, medication for opioid use disorders, or MAUD, medication for alcohol use disorders. So presenters and speakers may be using those interchangeably. Our featured presentation will be with Dr. Joy Brunson-Nsuka. Okay, as always, you guys found yourself here, so you most likely know this website, but talk.crisisnow.com. You can register for the Crisis Jam, which you have to do to get in, and everyone has to register individually. But also you can get all of the previous materials, click on previous recordings. So all that's great. And then the last week's Crisis Jam, if you did not see that, go ahead and check it out. It's on models of funding. This is great. I know we all are coming down from our Olympics high. So as you may remember, in the previous Olympics, Simone Biles had to pull out for mental health issues. She got a lot of flack for that. And she came back really strong in this Olympics, obviously, but did a great deal of talking about how the necessity to care for herself also led to her current successes, and also did a good clap back at her critics. We want to talk a little bit about the 988-day activation workshop that SAMHSA hosted, and I believe we have a speaker, Stacy Pulaski. Are you in the room with us?
I am, Aisha.
Oh, great. I'll turn it to you.
So some of you may have attended our really well-attended workshop earlier this week. And for those of you who did, we thank you. On September 8th, which is 9/8, we are doing 988 Day. And we're encouraging organizations, everyone around the country to help us create positive buzz around 988. Any activity around the country is up for grabs. We want people to have fun. Take selfies with 988 and no judgment, just help. This is a tagline that has been testing really well for us, which is why we have decided that we really want to use this phrase for this year for 988 Day. And we want folks to really just have fun with it. And then anything that people do, we want you to be able just hashtag 988 Day in social media, whatever platform. We have a wall that will be gathering what everyone around the country is doing. And we'll be highlighting some things on the 988 Lifeline social media throughout that day as well.
Thanks so much, and congratulations on the day. I heard you all had nearly 1,000 folks join, so it just speaks to the importance of this work. Thanks so much for talking about it.
Thank you.
This is a little bit of a call to action. As you all know, Moving America's Soul on Suicide is a fantastic movie that you can reach on YouTube. And now the Crisis Jam folks are trying to hit 1 million viewers. They're very, very close. So go ahead, get out your phone, scan that QR code to get you to YouTube, or go to the website there on the top of the slide and take a look if you haven't seen it, or watch it again. It's worth watching again. All right, one of my favorite parts of the jam, Crisis Trivia Hot Seat. So this one is this one is for all of us. So we are all now on the hot seat. We don't have a specific person. So everyone put on your thinking caps. This question is from the vault, about 2.5 years old. So if you've been here before, you got an advantage. Dr. Margie Balfour is a psychiatrist and national leader in crisis care, QI, and police response at Connections Health Solutions. She reports that 15% of adults present to their crisis facilities with substance use disorder as primary. So the question is, as soon as the options pop up, how many have a substance use diagnosis and or a positive toxicology? Is it 35%, 45, 55, or 65? And you should see a pop-up screen where you can go ahead and choose. So good luck to us all, and let's see how we do. I hope everyone got the chance to choose widely. I'm excited to see it's an extremely smart room of Crisis Jam participants, so I have high hopes for us getting this right. All right. So, all right, well, actually kind of a pretty relatively split room. So about a third of us, a little more than a third, thought 45, 55, and then 65, kind of split. So let's see how we did. And the answer is 65%. Methamphetamine and alcohol accounted for 75% diagnoses, and crisis receiving services benefit from medically, because of that. We know that crisis services benefit from medically monitored detoxification capabilities and other types of evidence-based substance use treatment. So definitely a high number, but if you think about the SUD diagnosis and or positive toxicology, that's what really gets you up to that pretty significant indication of comorbidity. So nice work, guys. Congratulations.
Yeah.
Oh yeah, is Margie on? Yeah, go ahead.
I am
Margie.
here. Yes. And that's probably an underestimate because at that time, there's not a point of care like urine test that you can do, without sending it off to like a real lab for fentanyl. I think we may have found one. Those have been sort of slow to get developed, but so that doesn't really include people who would be positive only for fentanyl. That's when you like break it down in terms of what we did see, most of it was on the West Coast, in Arizona, where we have a lot of meth. So I think it's like 50% were positive for meth, of those who were positive for something. And then I think it's like 25% alcohol, then followed by opiates. But again, that opiates is probably an underestimate.
Mm-hmm. That's amazing. It's start to think about this maybe even being an undercount, but really hits home the idea that we can't have a system that really bifurcates care for mental health and substance use, particularly at the point of crisis. And there's also a question on age in the chat, if you have a chance. But
yes,
I also know
you did have it broken down by age, and for kids, I think it was closer to like 35%, I think were positive or had a diagnosis. And for that, most of it was cannabis, followed by opiates and alcohol.
Oh, thank you. And then congratulations on this coming forward. Do you want to talk a little bit about this book with you and Dr. Goldman?
Sure. So for those who've not familiar with Psychiatric Clinics of North America, they are a well-known academic journal where every issue they invite guest editors, and then it has a theme. And so Matt Goldman and I did the one that is coming out in this fall, I think in September. And it is on crisis services. So I think there's probably quite a few Crisis Jam participants who were invited authors on some of these chapters, but it basically ends up being like a book. And it has the table of contents, I think, would be on the link there. But we tried to dig into some topics kind of in more depth. So there's a chapter on youth services. There's chapters on achieving health equity. There's chapters on working with law enforcement, mobile crisis facilities. So there's, hopefully people will find this helpful. And yeah, it comes out soon. A lot of them, if you go to their website, a lot of them are online ahead of print already. but the actual like print version comes out in September. And it may be, if you don't have access to a library, it may be behind a paywall, but if you're interested in any of the specific chapters, just send me or Matt an email and we can send those to you.
Oh, that's a great offer, Margie. And I think it's undoubtedly people will find this very useful. So congrats to you and Matt and to all of the authors on that. Fantastic work. All right, so let's go ahead and dive right in. I'm going to bring up Dr. Joy Brunson-Nsuga, who is the Chief Operating Officer at RI International. Joy, can I turn it to you?
Absolutely. Absolutely. Thank you. So I would like to get started to talk about medication-assisted treatment. As we talked about before, there's MAT, there's MOUD, there's MAOUD. So we'll be using these terms interchangeably throughout and also throughout this presentation. So I wanted to start with just some data from 2022 and 2023 to show the number of opioid related overdose deaths in the US, as well as the number of individuals that report symptoms related to alcohol misuse. Even though these statistics are down by 3% in 2023, as you can see, it's still a big problem and also a big concern. And next slide. Even though it is a big concern right now, I wanted to make sure that we remember that during the mid 19th century, up until this point, we've had different waves of concerns with opioids. So thinking about the American Civil War, thinking about the discovery of morphine going through the 1980s into the 2000s, when we were in the wave of prescription pain pills and adding in the pain scale, looking at the second wave in 2016, and now we're calling this wave that includes fentanyl and xylazine the actual fourth wave. So this has been an issue for years, and now it's really getting the focus that it needs as far as treatment and care and working to decrease that stigma. So understanding what medication-assisted treatment is, it is a comprehensive approach to treating substance use disorders, thinking about that medication and therapy all together, looking at basic needs, making sure we are looking at the whole patient approach to care. It's not a kind of one size fits all, but really working to make sure that the individual's concerns are addressed. As far as the substance use disorder, and that medication is a part of that. It is a harm reduction approach. So it isn't abstinence only, but really meeting the individual where they are, working on the physical and psychological aspects of addiction, while also supporting with behavioral therapies and counseling as well. And research has also shown that this approach also enhances the overall community well-being. So how does it work? So it's medications, like I said, medications and counseling. Some of the medications that you probably heard before are methadone, buprenorphine, vivitrol, naltrexone. They work to support the brain chemistry and to block the euphoric effects of alcohol and opioids specifically, and also to work with relieving cravings and working on for individuals not to go into withdrawal. And so being able to support someone from a physical standpoint with medications really supports them to be able to work with a counselor, work with support services, and by having this approach, it really helps to significantly increase an individual's ability to sustain recovery, help prevent relapse, and really work with individuals on all of the other things that they have going on as well, while the medication supports them from a physiological standpoint and normalizing that brain chemistry. So it's all of that together to help someone that is having opioid use disorder or alcohol use disorder, and making sure that they have the tools that they need to sustain their recovery. So for recovery innovations, we started looking at the gaps that we were seeing for our facility-based crisis services across the country. And the gaps that we were seeing specifically related to individuals that were coming into these crisis facilities that we have. And we were not able to address the individual's needs. We were not keeping up with the research and the evidence-based practices. And so with that, we were seeing that over 80% of the individuals that were coming into our facilities, and we are across the country, so that number can vary based on the actual location, but at our highest, we were at 80%. We were not able to address their individual needs of those individuals because we were not offering MAT at that time. We were offering detoxification services, but not MAT. So we started working towards addressing these gaps in 2018. So some of the steps that we took, we started with research, and we started in a community-based approach, a systems approach. So we started with research, and at first we started looking at whether our local hospitals could support based on some of the research and articles where EDs were starting to do inductions of buprenorphine. But within the community that we started, we determined that the crisis facility would be a better approach. So we started with research on how we could do this, looking at the 3-day rule to make sure that we were in compliance. We did a data review on the individuals that were coming into the facility. We did a community assessment to see exactly how many OTPs were in the community, how many OBOTs were in the community, and making sure that we had a good referral source, because starting someone on treatment or continuing someone in treatment, we needed to have a good follow-up plan. So we had to do a good community assessment to make sure we had good pathways to be able to support this work. We updated our screenings and assessment tools, making sure that we had appropriate tools to screen for opiate use disorder and for alcohol use disorder. We actually started utilizing the fentanyl dips into our point of care urine drug screens as well, to be able to get a more accurate count of individuals that were coming in. We had to make sure the medications were available. There were so many steps to make sure we had everything that we needed. And as you can imagine, throughout the country, DEA rules can change, the local county rules can change. So we had to do this over and over and over as we moved this process across the country. So making sure we had the medications available, proper protocols, and training of our team members. The training of our team members was one that we took a lot of care and focus on because these were the individuals that were going to be greeting all of our guests when they came in. What we found, which we thought was very interesting, was that there was a difference in our team members and their view on starting medication-assisted treatment within the facility. And what that means is that within the facility, we have a lot of peer support specialists who are fantastic at working with individuals in recovery, talking about their own lived experience, but also had a definite view on medication-assisted treatment. So a lot of training and time went into making sure that our team members were up to speed. They were aware of this evidence-based practice and why we were starting to actually go down this path for individuals. And then finally, it was implementation and then continued analysis. Next slide, please. So we started off small. We started with one pilot project. We had some successes, and in that pilot project, we started with inductions of buprenorphine on our unit. We started with continuations of buprenorphine if someone came in for a different crisis reason, and we started with continuations of methadone if someone came in for a different crisis reason. Those were all successful. And now, since then, we have also moved to offering Vivitrol as an option. And we've also moved to offering buprenorphine assisted withdrawal process as well, as it helps with the withdrawal symptoms, and then making sure that we are able to assist people with just being more comfortable during that process when they're in the facility. So we saw a lot of success with that one pilot project, but we also saw some challenges. And some of those challenges were centered around the myths that are around MAT. We saw this within the facility, and we saw it within our external partners as well. And some of the challenges that we had externally was within our community, housing options when we would discharge someone weren't readily available anymore. Talking to individuals in the community about resources that we typically had used before, we couldn't use for the individuals that were now on medication assisted treatment. And so we had a lot of work to do as a system to make sure that that individuals got the support that they needed. We also determined that we needed to start our own bridging OBOT clinic because we lacked capacity in the community in order to discharge someone effectively when we had finished our treatment within the crisis space. Next slide, please. And then overall, we just saw a very big difference within our substance use community, our overall behavioral health community. If we can keep going through this slide, as we started to work to make sure that we had the resources that we needed to provide this service. And so there was this push and pull between our thoughts on harm reduction versus detox. There was a push and pull for the cost of it, and also who had access to it. And then there was a push and pull around what we know as addiction as a disease. And MAT as evidence-based treatment for that, and the thought to criminalize behaviors. And there was just this push and pull that we kept having throughout the community as we started this service back in 2018, and worked with this internally for our own staff and then externally with our community as well. But since then, we've seen a lot of changes over the landscape, a lot of changes. As we have learned all the things that we started, all the barriers that we had to get started, we've seen over the last 5 to 6 years, medications becoming more affordable, not only for our crisis facility to be able to provide them, but also medications for individuals to be able to support their treatment becoming more affordable. We've seen communities that we're in have more of an increased focus on harm reduction methods. We actually have syringe exchange programs outside of some of our facilities as well. So we are starting to really become partners in the community. We've seen relaxing of regulatory systems. Specifically, one that I'm thinking about is related to the X waiver for physicians and that training time. We've seen more bipartisan support for treatment as well as the opioid settlement dollars, which has also helped. So now the bridge clinic that we started in our pilot program, there isn't as much of a need for it because of all the things that have relapsed. And then a response to critical community systems. We've seen EMS started doing inductions in the field. We've seen ED starting to do inductions. We've seen our detention centers starting to do inductions and continuations. And so we've just seen a relaxing of a lot of these systems over time that has helped us push our efforts forward. And lastly, the go forward. As I mentioned before, we are in the fourth wave. We have seen an increase, of course, in fentanyl and xylazine, which is changing the way our services are being provided. We're seeing much higher doses being required for individuals. We've seen more microdosing being required. So really, we've had to continue to evolve over the last 5 to 6 years to make sure that we're keeping up with the substances that are out there. And it's an ever evolving system. And so from my perspective, going forward, as we think about the crisis continuum, the call center, the mobile response teams, and the crisis facilities, making sure that we are thinking about substance use services as a part of the overall behavioral health services, and it's not separate, it is included, and that we have the appropriate assessments and screenings, tools, resources, training on evidence-based practices like MAT, and making sure that we're integrating these services so that individuals are able to get referred to the resources that best fit their needs. And as we continue to do this, we'll be able to continue to serve the whole person that is in crisis. And I know I'm probably running out of time, but I would like to make sure I highlight that August 31st is International Overdose Awareness Day. It is August 31st of every single year. You can find resources online. These are just some of the social media posts and all of that. They have them available for you, already created. So I just want to make sure that I plugged, because this is something that we make sure that we recognize at RI. So I just wanted to make sure that I did talk about that here. It is August 31st.
Thank you so much, Joy. That was fantastic. And often this group puts questions in the chat, so keep an eye out for that. But in the meantime, I want to call forward our roundtable discussants. First, we have Dr. Rochelle Head-Dunham. Rochelle.
Good morning. Thank you all for this opportunity, and more importantly, Joy, I really appreciate those introductory comments. I want to just share a few thoughts with you all. I was asked to do a high-level review, I guess because I'm an addictionologist and I've worked in this area of medicine for 34 years now. But a couple of things that sort of gleaned over the years. First of all, I like the acronym MSUD because we are talking about medicines for substance use disorder, to include tobacco. Tobacco probably has more medications that are available for use and is definitely the leading cause of preventable deaths from substances. So we can't forget about tobacco use. But in the context of MOUD, just three things I want to mention that are important and relevant. First of all, Joy has already mentioned harm reduction. Medications for substance use disorders is harm reduction. It is a significant component of harm reduction because it is the primary means at which we decrease morbidity and mortality. We see that most with opioid overdosages, but historically, we've always seen that in the treatment of substance use disorders. Alcohol and benzodiazepines also being very dangerous in high dosages and a cause for mortality and morbidity as well. So it is absolutely a part of harm reduction, but it also is a component of relapse prevention. When we talk about prevention in addiction treatment, it's important to get on the front end of the problem and not spend so much time on the back end of chasing symptoms that are far more out of control or more complicated to manage. So it is a component of relapse prevention. And then, of course, acute management, as I stated, because most people die from substance use because of the physical sequelae that occur when using substances. And so acute management is critical, and that often requires a hospital admission or an admission to a residential 3.7 withdrawal management type unit for services. So medications for opioid use, substance use are critical. The other point I want to make is about co-occurring disorders. In the world of addiction, co-occurring disorders is the rule. It is not the exception. And what I mean by that is that you have to look for it. If you don't look for substance use, you're going to miss it. And most of the data that is out there that is not taking into consideration professionals who are actually intentionally doing the appropriate screenings and the appropriate assessments are missing substance use disorders. Also something that you cannot eyeball and see. I've done this for many years and I will never tell you that somebody walks into my office and I can tell you whether they're a user or not. That also includes alcohol. You don't always smell intoxication. And so you have to test for it. And so looking for it is critical because it is more likely there than not in the context of the presence of a mental illness or not. So it is the rule for co-occurring disorders, so we have to look for it. The other thing is that we have to treat substance use disorder and mental illness both as primary conditions. Treating one in exception of the other is only going to allow for an exacerbation of symptoms from the one that's not treated. It's also going to ultimately undo whatever treatment you've done for the one that you've not made primary. So if we are treating substance use disorder, we have to be very, very conscientious about looking for mental illness. And if we're treating mental illness, we have to be very, very conscientious about looking for substance use disorders. There's a very complex interplay neurobiologically, psychologically between these categories of mental illness. And so we have to be astute about making sure that anybody who's touching one is also aware that they need to be looking for the others. These are chronic, relapsing conditions over time. They will ultimately undo whatever good work we're doing. So just a few comments about medications for opioid or substance use disorder. Thank you.
Thank you so much, Michelle. You're getting a lot of validation in the chat as well. Next up, Dr. Carlisle Johnson.
Hello. First of all, I just want to echo everything Dr. had done and just talked about. I was going to talk about co-occurring illness, and I will skip that. It was done so much better than I was going to say it. I work within a health plan in North Carolina that covers Medicaid and uninsured for 7 counties, about a third of the state. And one of the things that I've observed is that if we approach this crisis as health plans and as counties and as providers and as separate silos, we really miss the boat on being able to integrate systems of care, find ways to promote low threshold access to care, and find a way that our community benefits from the interventions we're working on. Some of the critical things that we really have been focusing on a lot is involving people with lived experience in the process of getting into care. If you think of someone who's been engaging or trying to engage with our healthcare system and may have very limited trust in that system, it really helps to have someone who has that lived experience who can help them navigate. Also, it's a lot harder to navigate a system where mental health and substance use are separated as separate silos than one where they're integrated together. And so anything we can do to promote that integration makes a world of a difference. We're also doing a lot of work within systems such as the criminal justice system. And if any of you are interested in this area, it's, I think, a critical area for all states to be looking at. Essentially, in most county detention centers across the country, most prisons, if you are receiving medication for opioid use disorder and are incarcerated, you are not able to stay on the methadone or buprenorphine or other products that you are receiving in the community. We know from research that the risk of overdose is 40 to 50 times higher in the 2 weeks after release than the general population. And it's an excellent opportunity to maintain people on their medication. It's also, our federal government has clarified it is a violation of the Americans with Disabilities Act and the 8th Amendment of the Constitution to deny treatment for opioid use disorder within detention centers. So many detention centers are getting on board with expanding treatment to be compliant with ADA and 8th Amendment. Others are being litigated to that point, but we're working with the systems of criminal justice as well as hospitals, EMS post-overdose response. And really, I think the ideal to me is to bring together all the partners, put aside any territoriality or blinders as far as how to approach this, and start with the end in mind and say, how do we engage people at the point they're at, meet them where they're at, and get them into treatment, eliminate the barriers, and particularly some of the financial barriers, some of the bureaucratic barriers. There are workarounds that I think are the critical work of collective impact groups to make our system more accessible, low threshold access, easy to get into treatment, and also systems that do not kick you out of treatment for displaying the symptoms of substance use that got you in, such as testing positive for marijuana if you're in an opioid treatment program. So there's so much that can be done. I appreciate you focusing on this, and thanks for inviting me.
No, thank you. That was fantastic. And thanks also in particular for raising the criminal justice system, where for many of our counties, our jails are the primary or largest behavioral health provider. And too often they're not providing MSUD, and certainly, as you noted, moving people around in terms of what they're getting. So thank you so much for that. Next up, Mr. Lem Scott, your reflections. Lem, are you here? Oh, okay. Well, we seem to have lost Lem at this moment. And if he joins the next couple of seconds, we'll be able to get him on. But given that, I want to just open it up a little bit now in case that other folks in the room that might have additional comments, that there are questions that they'd like to raise. I know Margie, you've already spoken, but you've done tons of work on this topic. Or otherwise, Joy, if you yourself would like to come forward. Well, let me ask this, Joy, since we have a couple minutes. I know one of the earlier questions in the chat was just, or one of the comments was really talking just about how much they really appreciated the steps that you all took to really shift the way your system focused on substance use disorders. I know this is a big question in probably 2 minutes, but could you talk through some of the steps that were the most challenging for you, and what some of the specific changes you made were?
Sure. I think the steps that were the most challenging for us, and my background is in systems, so I like to really focus on the entire system when we're making changes. I think one that was the most challenging was setting up that follow through and that aftercare. I think that part of it is critical and important. Crisis services are always going to be short term. So making sure that there is not only family education, making sure that we provided Narcan kits and training on kits, making sure that we provided comprehensive follow-up care and appointments that included supporting basic needs. Like that whole process, I think was challenging, and making sure that we had the right supports in place. As I talked about, our community when we started wasn't as receptive to what we were trying to do. So we really had to have a lot of discussion around what was needed, making sure that we had all the pieces in place. I think at that point, the easiest was getting the Narcan kits, because there was a lot of push in the area to provide those. But all of the other pieces, including making sure individuals were able to thrive in the community once they discharged, was probably one of the most challenging for us.
That's fantastic. Thank you. Yeah, I think one of the most challenging things you do hear about making these types of changes is noting where the resistance is inside the house, like where your own challenges, your own staff, your own culture has to shift and to really incorporate this type of care. And then absolutely that sort of making sure people are connected and stable after they leave you doors. So thank you so much, Joy, and thanks for the work. Thank you to all of our discussants. Other folks on the call, please do jump in the chat with your thoughts, questions. We've got folks. Margie, I just saw you click on video. Did you want to jump in?
Oh, yeah, and just echoing everything that was said, and in starting people on medicated assisted treatment, like Suboxone, for example, that was actually the easiest part. Like, training the docs and training the nurses, like that part was actually straightforward and easy. The hardest part then was figuring out how, if we're going to start people on this path, how do we make sure that they have the right follow-up? And in the early days of the opiate epidemic, we actually couldn't get people in within like a day or two, and had to start our own opiate clinics, which we've, since divested from. But it's really those partnerships, working with agencies to get us the Narcan and, things like that, like knowing who to connect people to. And there's still a ton of stigma out there. There's still a lot of homeless programs that won't take people who are on any kind of medication assisted treatment. And that's a huge problem. So a lot of that stigma that exists, just systemic stigma, still needs to be addressed. And then, opiates, we're very lucky that we've got some really good treatments for that, as well as alcohol and tobacco. What we still struggle with the most is meth. And, I had a little cadre of, when we had our opiate clinic, a little cadre of patients who were doing really well in terms of their opiate addiction, but couldn't kick the meth. And then the meth has fentanyl in it, and so it's risky. And, there's some emerging evidence of, there's a lot of them that had co-occurring ADHD, and no one would give them stimulants because they had a substance use history. And, all that stigma, I think, also plays into how successful these folks can be in getting the right treatment.
No, thank you so much for raising that and for validating what you've heard, but also talking about the struggles that you all had and how you got around them. So really appreciate it, Margie. Thanks for jumping back in. Okay, we are going to go ahead and get to our partner updates. So Dr. Belina Shaw for SAMHSA, can I bring you forward?
Good afternoon. Glad to be here on the Crisis Jam again for the SAMHSA update. A few updates, and I just also want to comment a little bit on that great discussion on co-occurring disorders and substance use disorder. I am an addiction psychiatrist as well, and I used to chair our overdose fatality review team in our local community. And I will just say that there were so many people that we had seen who had died and who had passed away from opioid related deaths. But when we look back at their history, we only saw mental health or maybe alcohol, but not necessarily that opioid. And so I just want to reiterate that this is really a life-saving concept, and this is not just a good to do, but this no wrong door really can save lives, because you really just don't know all of the depths of someone's history and needs until you really start to understand them. And I love the term MSUD, just thinking about not specific to alcohol or opioids, but just in general, when we taught of the older term MAT, MAT is thinking it's medication assisted treatment, but just decreasing stigma. One other layer, medications for opioid use disorder, alcohol use disorder, tobacco, whatever those medications may be, that those all are treatment in themselves, and that they're not assisting the treatment. So I'm just so glad to hear the terms shifting from there. And I love the MSUD. I've never heard that, but I look forward to using it. And so one last thing is also making sure that you do have, I love how Joy mentioned that they did the comprehensive assessment. And I would add the and to that is that if you don't have the medications available and say you look at your own data in an institution or organization, you don't have the medications available, people will underreport. We saw that in our jail, that as soon as we started offering the medications, that people started increasing the reporting because there was a reason. So also just if you think it's not really a problem, you may not know the extent of the problem until people feel like there's a need to tell you. Otherwise, with stigma, why bother? So my really quick SAMHSA update is that we next week are having a summit focused on the national guidelines. As you probably have heard in this this context before, we are working on several guidance documents related to the crisis continuum, all simultaneously. I love seeing Microsoft Word every day, but they are the Mobile Crisis Toolkit, which I will say is co-funded by the Center for Mental Health Services and the Center for Substance Abuse Treatment through the block grants. And then also with support of the 988 office as well. So we just once again, we know that needs to be a co-occurring approach. That document is well on its way. We are also working on standards and definitions, clarifying what exactly does each of these levels of care mean, and just really creating some outlines for the puzzle pieces, as I like to say, so that we know what those shapes are exactly. And then the third guidance document is an update to the national guidelines. We know that the 2020 guidelines were created prior to the 988 rollout, and there's some other really exciting things that are going on now with moving towards geo-routing, et cetera. And so we want to make sure that we're up to date with this very burgeoning, growing field and the crisis care continuum. And we will be assembling a group of experts to review some drafts of some of these documents and helping us to give feedback and really practice-based evidence, knowledge and understanding that they'll share with us, knowing that there's just a lot to learn. So we're looking forward to this iterative process. There will still be opportunity for public comment for these documents, and stay tuned. And that's my major SAMHSA update.
Thank you so much. Next up, we have the NASHBID update. Wendy Morris.
All right. Well, hello, everyone. Great to be here. I'm going to spend my update talking a little bit about our Transformation Transfer Initiative, or TTI, here. In 2007, SAMHSA, in collaboration with NASHBID, created the TTI to really help states to transform their mental health systems of care. It's a kind of a modest funding that's awarded on a competitive basis to really help states and territories with some new innovative ideas. It's very flexible funding, and it can be used either for a new initiative or expansion of one that's already underway. It can focus on one or multiple phases of system change. And then in addition to that funding that can be awarded to the states, there's been a creation over the years of resources such as informational exchanges, social marketing material, and resource guides that are helping those who are participating in an initiative. We have a phenomenal team at NASHBID of folks who help the awardees. They provide a lot of technical assistance, link them to other states or other resources to help move their projects along. And we also partner with NRI, the NASHBID Research Institute, who helps states with evaluations. So through this TTI over the years, SAMHSA has invested more than $50 million to over 250 innovative initiatives that have spanned 49 states, 5 territories, and the District of Columbia. So over the years, the topics have varied, but for the past 3 years, they have focused on crisis services, and that includes 988. So in 2024, some of those specific topics were rapid access, workforce, support employment, high-risk populations, 988 and 911 collaboration. And if you visit our website, there's a brief description of every project. There were 50 projects, 50 awards made in 2024. And the reason I'm talking about it today is because we are just wrapping up this week. We're having our final calls with the states for their technical assistance portion. They'll continue that work and have evaluation meetings with NRI in a few months. but we're also about to embark on the application process for 2025. So I just want to make sure folks know that it's available. While we are not able to publicly share the topics for 2025, we have had a sneak preview of what we believe they'll be. And I think we're going to see some exciting things come out of it. So we're hoping folks will look for those applications. They'll be available on our website at the beginning, early part, maybe mid-September. The state mental health authority can apply for those, but if you don't work for a state mental health authority, I would encourage you to seek them out and see if there's opportunity for collaboration, either on a TTI project or maybe some other projects. And we know that collaboration can lend itself to some great collective impact and really exponentially improve outcomes and get some synergy going to move things along. So maybe more to come about that next month. So thank you.
That's great. Thank you so much, Wendy. We'll keep an eye out for those applications. Exciting. All right. Next up, Stephanie Hepburn to talk with us about an article that's a couple of years old, but is just as relevant today as it was then on stigma and MAT in the recovery community. Stephanie, go ahead.
Aisha. So I'm going to bring on Dr. Chuck. So the article focused on persistent stigma against MSUD. I love that. Thank you for that. I think that was Dr. Head Dunham in the peer recovery community. And the interviewee for the article is an award-winning peer recovery coach who credits ongoing MSUD and caring recovery coaches for her own recovery. But she's also witnessed persistent stigma within the recovery community, so much so that she hasn't felt comfortable sharing her experience. And I wanted to bring on Dr. Chuck to get his thoughts.
Thanks, Stephanie. It's really interesting. I just realized I was going to be doing this within a short period of time, and I bumped into Veronica earlier this week, not knowing this was coming up, and she's doing fantastic as always. I would have loved to have asked her, because this is one of those things, just like when I talked with Tom Betlock last week about how his article had changed since 2023. And this article was what, several years ago?
That's right. It was 2019. Yeah.
So it mirrored what some of the things that Joy described that we had to combat within our staff of stigma. Although the article, I loved it, also talked about stigma within the general population. I do feel like that both within my experiences professionally within our staff, as well as seeing things in the general population and in the general medical community, there's been such an improvement from where it was when this article came of decreasing stigma, such as seeing, changes in emergency department procedures, finally starting to see new options for folks who are coming out of crisis and need next supports for like residential substance use treatment, being allowed to be on MSUD as part of their regimen. And then the best part is seeing the change in stigma within our staff, which is who I get to see the most. We actually now at RI have staff members who are open about their use of MOUD or other alternatives and share that. And we've seen just an overall trend in that so improving. It doesn't mean there's still not a long way to go. I can tell you about a very challenging discussion in a local county talking about it, and some of the decision makers having so much misunderstanding of what this is all about and what it can do. So the article was fantastic of stating that. I think it still totally applies today, but I do share a hope that I really have seen improvement from my experience. I think Veronica would say the same thing. I wish I had known this was coming up and say, hey, would you like to have been? I just didn't know it was coming.
I would love to do a follow-up with her to see if her sentiments have changed. I mean, I think one thing that stood out to me was one of her quotes. And she was talking about, and that kind of reminds me of what you were talking about at the community meeting. But she said that at a team meeting, a colleague vented that Narcan enables people addicted to opioids, saying, we'll bring them back and they will just use again. And she didn't respond in the meeting. But internally, and what she told me is, it took me multiple times to get there. What if people at the clinic had just given up on me? Where would I be? We want to do our best to create an environment for people to get the help that they need when they need it. And so that's, I'm curious, you've got Dr. Balfour mentioned this too, you have this sort of, systemic, I feel like we've done a great job as a society pushing back on depression and anxiety. And it's almost been, it seems like more digestible for people. And this concept, for some reason, with SUD, it seems to be, the stigma seems to be holding tighter. And I just was wondering if you've seen that as well. In that community meeting, can you share a little bit about what you were seeing?
Ooh, it was a educated person with multiple years of postgraduate work using some of the typical myths and stigma about MOUD. That SAMHSA has great tips and things to share for the family on their website to help combat, and raw data that helps completely say, no, that's actually completely false. But I think that it's something that's out there still. But like I said, overwhelmingly, there's so much of a stronger voice on the other side combating that and doing that. And I see it on the funder side. And that's what I think is just so important for this crisis jam. And I hope this session continues to help push forward this idea of this is a really important part of our overall services that we offer to the people that come in crisis at all layers of that call center, having resources and understanding about those things, mobile teams having understandings and where they fit within that, all areas of the continuum, and then that next follow-up step like Margie discussed and Joy discussed.
Thank you so much. Thanks, Dr. Chuck. I'll pass it back.
Thank you. Thank you both. Thank you both. And actually, I'm gonna just see if Tanja Miles is here and could give just a quick, very quick reflection, because Tanja, I know you've done a ton of great work in this space as well.
So can you guys hear me?
Yes, yes.
So I'm just super excited about, everything that everybody's saying, because at the end of the day, it's going to take all of us working together. And look, we know the data don't lie. And because of the many people who are on this call, right now in East Baton Rouge Parish, we have seen a decrease in drug overdose in the past 6 months on a continual basis. We have the data to prove it. And it's because we have certified peers who are on the street from 6 a.m. to 12 midnight, 7 days a week, who go out on every POD. And when we encounter someone who has experienced a drug overdose, a non-fatal, we're able to talk to them about MAT, about treatment. And, we're grateful for the Bridge Center that if they're ready, they can go straight there. And also if that, person is fatal, we're offering hope, resources, Narcan, fentanyl testing strips and things like that to their family members. And we're also going out in those hot spots where we see that drug overdoses are happening more every day and providing a lot of, harm reduction. And we're talking to people about MAT treatment. So we know it's working. And next week, I will be meeting with Senator Bill Cassidy, who's the ranking file member on the Senate Education, all that other committee, because now there's no oversight for drug overdose, the settlement, the opioid settlement money. And so he have asked, me to help him to do legislation that'll be oversight, among all states who are getting, that settlement money. And of course, a big push is going to be to address treatment, stigma, like you guys talked about, and how do we make sure that people know about MAT?
Thank you so much, Tanja, for the work and for the wisdom. Now bring us home, Vic Armstrong with Strong Talk.
Thank you so much. The way we individually and collectively navigate and make sense of the world, the way we define ourselves is heavily influenced by lived or living experience. The things that we live, the things we're taught, and the things we consistently hear, including beliefs and norms about mental health and addictions that may be passed on from generation to generation. This experience helps us form our narrative of the world. It's the way we frame things, the way we make sense of the world. It helps us find our community and write our story. As I was preparing these words for today, I found a definition that described community as a feeling of fellowship with others as a result of sharing common attitudes, interests, and goals. We are a community united in service, and we have a story. And the good thing about this story is that we're not just the actors. We are the authors, the creators, and the conductors of our own story. And our story is not a tragedy. It's not a horror flick, and it's certainly not a romantic comedy. Our story, the story of this community, is an epic about a community coming together from different organizations, different races, cultures, ethnicities, sexual orientation, and geography, uniting as one behind a common cause, creating help that feels like help, creating community that feels like community. And as one community, one crisis services community with one story, we can be the change we wish to see. As one community, we can transform to a crisis response system created in partnership with individuals with lived experience, a system designed to protect and nurture the individual experiencing a mental health emergency, rather than a system designed to protect the rest of us from the individual experiencing a mental health emergency. As one community, we can move from being an under-resourced mental health system to a system that has the resources and cultural humility to meet the never-ending demand for hope, help, and connection, a system that reimagines connectivity, re-engages our communities, and reestablishes relationships with communities where people live, work, and play. Our story, the story of this community, is not just a story about the fight for resources, the fight to overcome stigma and discrimination, the fight to decriminalize mental illness. It is a story of resilience. It's a story of perseverance and a story of victory. I know that sometimes we can all in this fight become weary. We can all become frustrated. We can all become discouraged, even fearful. But that is the beauty of having a community with you. That is the beauty of our story. And in closing, in the words of former First Lady Michelle Obama, history has shown us that courage can be contagious and hope can take on a life of its own. We are one community, one story, and that is Strong Talk.
Thank you so much. Thank you all for being here today for this discussion on MSUD and crisis services. Next week, we have 988 and a focus on LGBTQ youth and specialized services. So meet us here next Wednesday for that. And thank you all.